Hello, everyone, and welcome to CME Palooza Spring 2021. I am Scott Kober, one of the co-producers of CME Palooza, and I would like to welcome you to our kickoff session of CME Palooza Spring, entitled How Digital Platforms, Artificial Intelligence, and Cognitive Learning are Transforming the CME Learning Experience. This is one of our gold sponsor sessions. This session is sponsored by Projects in Knowledge. Our moderator for this session, who I will bring on in a moment, is Bob Stern. Bob is the president and CEO of Projects in Knowledge. So as with all of our CME Palooza sessions, before we begin, I would like to thank our sponsors, our gold sponsors, Med Learning Group, Physicians Education Resource, Projects in Knowledge, our silver sponsors, Peer Audience, Academic CME, the Academy for Continued Healthcare Learning, Integrity CE, Hippocrates, Platform Q Health Education, and our many bronze sponsors, Antidote Education Company, PVI, CMEology, Haymarket Medical Education, Vindico Medical Education, Medscape Education, RMEI Medical Education, Global Education Group. Here's the Global Education Group coffee mug. Thank you. Real CME, Answers in CME, Helio CME, Creative Educational Concepts, Integritas Communications, Infograph Ed, Prova Education, DKB Med, CME Outfitters, Evolve Medical Education, Spire Learning, Red Med Ed, Foresight Learning, and Excalibur Medical Education. So there are two ways to ask questions during this and all of our CME Palooza sessions. You can use the Creative Educational Concepts text line to send in a question. The number is 267-666-0CME, that's 0263. Or you can tweet your question to us using the CME Palooza hashtag. So we are going to be using Poll Everywhere audience response technology during all of the CME Palooza spring sessions. So if you want to participate using the Peer Audience ARS system, you can either download the Poll Everywhere app and join the presentation entitled CME Palooza 005, or type in the following URL in your web browser, and you can all read that yourselves. I will kind of put that up on the screen here as we're kind of going along. Finally, a brief speaker disclosure. Please note that the opinions, discussions, and/or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, its parent company, or their affiliates. And so with that, I am going to turn things over to Bob to introduce the rest of our panel and start the session.
Thank you, Scott, and thanks to you and Derek for producing this, and appreciate your help along the way on this. And welcome to our session on digital platforms, AI and cognitive learning. So I'm Bob Stern. I'd like to introduce our panel, which is a great panel, of which most of you know the leading lights here. Dale Coomerly, who leadership in medical education, both at BMS and at Merck, everyone knows, and his leading position and advocate of new technologies at the board of directors at GAME. John Ruggiero, head director, medical external affairs at Daiichi Sankyo, also from Genentech and at Daiichi Sankyo, always looking forward to new technologies and how it could impact in the medical education field. Doug Seifert, who is the president of, and CEO of Scientis, who is going to talk about a really cool technology on learning, which I find fascinating and will be very interesting to see how it evolves and continues to impact learning for physicians and healthcare professionals. David Setiatti, who he and I have worked together now for many years, and has really pulled AI technology and learning technologies to the forefront for us, and really sharing that knowledge with everyone out in the field. So thanks everyone for joining us. Really appreciate that you're here. And once again, welcome to everybody. So I think we're going to kick this off first by starting with an ARS question to see what's going on and what everybody's thinking about, so we can also address these issues during the presentation. So Scott, if you could start with the first ARS question, be great.
Okay, so our first ARS question, and I'll read you the choices. So what one choice best describes your perspective? So the choices are: I fully embrace and use a digital learning strategy. I don't fully understand the differences between online virtual learning and digital learning. I think I understand the differences, but do not think I possess the capacity to deploy or support. I do not believe a digital platform provides any diverse benefit to what I am already developing or supporting, or I think digital is simply the next buzzword. So if you are on the Poll Everywhere app, you can go to the CME Palooza 005 presentation, or the URL is on the top of this slide. And as we can see, people are already responding. So I'll give another couple seconds. Okay, so it definitely looks like the majority of people both embrace and use a digital learning strategy.
That's great to see, and that'll speak directly into what we're talking about today. So that's great. Scott, if you could pull up the first slide, differentiating the landscape. Thank you. So what we're going to do, what I would like to do now is really level set and differentiate, at least from my perspective, the difference between what we call digital learning. So there's the digital learning as a platform. So I look at Netflix and Kindle and webcasts, et cetera, as you can see on here, as digital, but as digital platforms, which is different than what we're going to talk about today. So we're going to talk about digital as what I call a computational research and CME tool. And that gives us the ability to really take a deep dive into the learning differences and what CME can bring out from a learning activity by being within the workflow and by experiencing simulations, clinical pathways, medical calculators, and also bringing in the patient voice, which I think is really, really important. So I think that's the difference of what we're going to be talking about today versus, I'll call it the mainstay CME distribution that we are commonly doing every single day, which is great, and educating a lot of physicians in many different ways. But I'm using digital as a different term rather than as a distribution platform. So I think what we're going to do now is I'm going to turn this over to John, and we're going to bring John's slide up. And John, I think you're going to bring this together, and Dale is going to follow with his addition to these slides as well, to this slide as well.
Sure. Thanks, Bob. So first of all, congratulations to CME Palooza for the amazing amount of sponsors for this program. It truly demonstrates the effective use of this educational tool for so many of us in the community. And I'm really proud and honored to be part of this panel. So I'm not here to invent some type of false narrative around me being an expert in digital learning, but I know enough to be dangerous and interested. And what I do know is that right now people feel disconnected and are asking for help. Clinicians who are already overextended and stressed are seeking easy solutions to remain at the forefront of science. And truly, if you ask them, they simply want to remain informed to address current patient needs. And we all saw that over the last year, HCPs have also expressed some kind of building chasm between the ability to have peer interactions compared to previous years. So, I mean, imagine there's a lot of psycho and social demands and requests to simplify life and work in general so that individuals can become more self-reliant and self-directed. I know we're going to discuss a lot of that today, but to me, this is a clear and direct call for the need to integrate learning science into our practices, and that includes digital learning. So I approach today with three distinct hats. One hat is a supporter from industry, the second is a science guy, and the third is an educator. As a supporter, what I'm hoping to see and be is quick dissemination of emerging or inconsistently applied data, and then also being a fiscal steward of budget that I'm responsible to lead. As a former biostatistician, I'm interested in seeing scientific measures around adoptions and barriers to adoption. And as an epidemiological researcher, I'm interested in seeing the understanding around those measures and trends of learning spread. But as part of the educational community, I want to be sure that the educational designs are effective for the identified gaps and that innovative methods are meeting the current demands of the recipients of education. So this is where I get to digital. The conversation has always existed. It's not new, but it's becoming even more prioritized now. There is definitely a difference between virtual online learning and digital learning. And you heard some of that with Bob's introduction. I'm not here to suggest that one is greater than the other because they both serve a distinct purpose. But when you have technology that generates, stores, and analyzes data that will be used for learners to take action, you're embarking on something that might start looking like a digital learning experience. So if you think about academia, often in academia, there are opportunities to flip the classroom and require students to do knowledge gain on their own and then come to a virtual experience to discuss cases and work. But we all know really well that HCPs are rather busy, and this type of structure doesn't always work to their advantage. Digital, to me, can often supplement the virtual experience or stand on its own as a framework of learning. It does require educational designer skills to pull learners into a mindset of self-motivation, perhaps by showing them their own data, and then providing simplified data-powered technology that they can use before, in the moment, or after to learn more, track data progress, and use data for practice change efforts. And if you go back to what I initially said in the beginning of my portion of this talk, people are feeling disconnected right now. And one of the best ways to overcome that disconnection is to allow for peers to network with one another to discuss really complex cases. But the continuous network is what's really important, and I think somehow captured in a digital experience. So as a supporter, I leave you with my introduction by saying my organization, as well as other supporters I know, are truly interested in seeing what type of digital opportunities come forward to us for review. I definitely do not think it is a buzzword that is new. I think that this is a capability that is going to be a really interesting tool to approach what the HCPs are demanding now. Perhaps maybe Dale has some perspective on this as well.
Thank you, John. Dale?
Yeah, no, thank you, John, and I want to offer my congratulations also to CME Palooza. Very much a very impressive list of supporters for this program. So the question that was posed to me was, how I see AI in learning today. How do we see artificial intelligence use today? So there are a couple of topics that I think about when considering the use of artificial intelligence in learning today. And of course, the first is, finding examples of artificial intelligence within many of the learning initiatives. We have many examples available today, and those will be discussed. I also think about machine language and AI to be used as tools that allow us as medical education professionals to perform our roles better than we currently are doing. And then thirdly, not enough people, healthcare professionals as well as patients, learn about and embrace the new digital healthcare technologies. And when I talk about the digital healthcare technologies, I'm talking about genomics, I'm talking about digital medicine and the digital education that John has just mentioned, AI, and then robotics. So there's a lot of, there's a lot of area in this. So when it comes to artificial intelligence within the many learning initiatives available today, we have multiple examples, and you're going to hear about some of those today. I, as a supporter in the past, have supported, MedSims, the at point of care suite of products, which you'll hear about today. We had artificial intelligence instituted as a part of a QI initiative when I did a program that I supported for Duke University. So there's a lot of examples out there, and you'll hear about some of those today. But what really interests me, though, is the use of AI and machine learning as tools that allow us as medical education professionals to perform our roles better. And I've had some, fortunate opportunities to start projects specifically in these areas that help us to do the heavy lifting of medical education. What I'm talking about particularly is educational needs assessment. So one of the areas where we can do a quick and easy literature search using natural language processing, machine learning to determine what are the true educational needs that are out there. In pharma, though, there's also other sources that we can use, whether it's market research, medical science liaison insights, previous outcomes reports. All of those things can be brought together and put into an educational needs assessment that really kind of helps us to understand the where the needs are, and for us to put our money where the needs are. That's really kind of an important point. We can also look at the grants that we receive, and we get educational needs assessments in those grant proposals, and we can compare what we have determined ourselves as the educational needs and compare those with the ones that we are receiving. I think an interesting point, too, is outcomes analysis and reporting, and connecting the outcomes and that we receive to the actual educational needs that were identified, and did we actually have an impact on those? And with machine learning and AI, I think there's an opportunity to do that across a broad number of activities that we do, as long as you have certain, qualities or certain met, criteria. The other thing I think too is the third thing is, of course, not enough people, healthcare professionals and patients, learn about or embrace the new digital technologies. We have many examples of healthcare professionals that have jobs that are augmented by artificial intelligence. I think many are leery that their jobs will be displaced by the digital healthcare technologies. As medical futurist Bertrand Mesko says, AI will not replace physicians, but physicians who use AI will replace those who do not. So I think it's important to note that, what he is saying here is that the way that the job is done was going to change, and augmented intelligence and digital technologies are going to change that quite significantly. There was a study that was done by Frey and Osborne that showed 47% of about 700 occupations are at risk for automation in 2030. So it's coming. We know that. John mentioned that. It's not something that's really that new. Automation has been happening since the Industrial Revolution started, but it's now starting to impact us in healthcare. I think the last thing that I want to point out here that I think about is that patients have to be digitally literate as well if they're going to embrace the next wave of healthcare applications and services that are provided by the healthcare professionals. I think a lot of times we talk about getting the healthcare professionals digitally literate, but it also is the patients that need to be digitally literate. And there's a lot of data that's been done and researched out there as to how poor it is actually here in the United States, how poor digital literacy is. So I'm happy to talk about that if there's any particular questions on that. But pass it back over to you, Bob.
Thank you, Dale and John. This is great input. And one of the things I'd like to add to this and to your comments is that physicians are already in a learning system. They have their EMR. They're getting a lot of information from AI readings in their scans, genomics, precision medicine. The health system has really embraced the the technology that allows a physician to do a better and more efficient job. As Dale said, it's not about replacing physicians. I think that was an early on thought that physicians were afraid of that. But I think as physicians have become more, and I'll say forced into the system, they really do see it as a help, rather than someone who's going to replace them. So the ability to be within the workflow for CME is not in the workflow right now for the most part. CME is exterior to the workflow, but bringing the CME into the workflow is really the goal, the challenge, the mission, the moonshot, whatever you want to call it. But helping the physician, the healthcare practitioners all through the system, NPs, PAs, pharmacists, do a better job by also learning during the time that they have cases in front of them. We do develop a lot of cases, but they have their real cases, don't they? They have their real cases in front of them. And the artificial intelligence is really a back-end language. It really isn't the front-end language. And it's nothing for us to fear. It's really about putting that into action so we can do the needs assessment and the gaps and be able to understand what is it that the clinician is really doing with the patient, what the patient is reporting back to the clinician, and how that all wraps up into their learning during the work day. So thanks, John and Dale, for those comments. I don't know, Doug, David, did you want to add anything to this part of the discussion?
I think also just to note in terms of digital as a distribution platform, I think it's becoming a necessity, even as a distribution platform, knowing that as per Elsevier, medical knowledge was doubling. In 2010, it was doubling every 3.5 years. According to Elsevier, currently it's doubling every 73 days. So just getting that knowledge out and all that content out, digital is definitely has to be leveraged to do that. So that's on the one side. And on the next side, as you talk about workflow, digital can work two ways. It doesn't just have to be a dissemination or distribution medium. There can be interactivity and engagement. And I think that talks more to what Dale was talking about as well with the AI and cognitive. Now there's ways that we can communicate, and as mentioned by John, in terms of measures can be communicated back and forth, and digital can be used as a medium for two-way interactivity. So I just want to add that.
Doug, did you want to add anything to this part?
You're on mute, Doug.
Yeah, I think it's both the level of interactivity that we have today, that and also the ability to collect the analytics in the back end that can really provide a lot of benefit on the digital realm that wasn't available before.
Thanks, Doug. I'm sorry, go ahead, Dale.
Yeah, no, I was just thinking too that when we're talking about the getting the use of these tools and the cognitive to physicians and stuff, I think one of the key things that oftentimes is missed is the ability for patients to actually engage. I know one of the big things that we talk about these days is, just shared decision making and including the patient at many levels. And I know a lot of the groups that I worked with, when I was, a supporter, was to include patients in all levels, even from the planning perspective. So it's really important to understand, though, that the true need is to get everybody, not just the healthcare professionals, but also the patients that are going to be impacted by this, to understand that. We know that only 1 in 3 adults, there's a study that was done that showed only 1 in 3 U.S. adults can actually demonstrate high proficiency in solving a scheduling task that involves email as well as several other programs. So it's a true digital literacy problem that we have right now that needs to be addressed as well if we're going to start using. I've got my watch here, my Apple Watch, which gives me, all of the abilities to do all kinds of monitoring. And, even as somebody technologically advanced as I like to think I am,
you are, Dale.
There's challenges to that, right? So, imagine folks that really don't have the skills of the digital literacy. That's one thing that I think CME people can do and companies can do, is to include them more in these discussions.
Thanks, Dale. I think that's very true, and that's certainly evidence of just trying to register to get a COVID shot, right? People are having all sorts of, not just trying to find out where they can get it, but just interfacing with the various cumbersome systems out there. We're living that every day. Just heard that again on our news report this morning. So thanks. John, did you want to follow up on anything on this?
No, not anything that's been mentioned, but I'm excited to hear what the rest of the conversation is going to bring, and we'll add some flavor to that.
Great. So, Scott, we have another ARS at this point before we get into the rest of the unveiling of different technologies. So, turn the ARS back to you, Scott.
Sure. So there are also a couple of questions that have been coming in on our CEC text line, but I'm going to hold on to those for the time being.
Okay.
I think some of it we're gonna talk about a little bit later. All right. So this is our peer audience ARS question. So this is one where you sort of have to kind of move things up and down on your screen. So in order of frequency of use, how often do you design or support digital education for the following? And then there are 1, 2, 3, 4, 5, 6, 7 choices, 8 choices. So if you're in the Poll Everywhere platform, you can click on things and you'll see it, how you'll be able to move things up and down. And then when you're done, you can click the submit response button. So your choices are learner collaborations on shared learning projects, practice of subject-specific skills, simulations, clinical decision support, research using the internet, creating protocols, collecting or analyzing data, and simulations. So like I said, you can move things up and down. I'll give people a couple seconds, and kind of as we're kind of seeing the results come in, you're going to see things shifting a little bit based upon how people are using some of these materials.
So, hey, Scott, are these results going to be available afterwards? Will we be able to see these?
They can, yeah. I mean, we can certainly download and post the results from all of our peer audience ARS questions somewhere.
Yeah, that's very interesting. How many people do we have on this morning?
We have 147 people who are currently on this session.
So that's some good data.
Yeah, no, this is great data.
It's really good data. And I think that as people are just evaluating the way that they would answer this question, for those who are trying to learn more about the digital experience, these questions or these topics provide a good foundational list of what digital might actually mean too. So if I were part of the learning audience that are trying to increase your knowledge around digital, I'd screenshot or screen capture this because it provides a good list of categories, in my perspective.
Yeah, you're right, John. And I think, too, a lot of them are interconnected as well, right?
Yeah.
Okay. I think that's probably enough time for this. So, Bob, I'm going to advance the slide if you want to move on to the next.
Yeah, that's great. Although it's interesting, looking at this, I definitely will bother Scott for a screenshot of this at some point. But let's move on to the next slide. So what we've talked about so far is the ability to how do we get this AI and machine learning to be something that everyone feels is very comfortable with and is really a back-end tool. So if you think about AI and machine learning, it's really about the reporting and the metrics that can be given back to learners and to health systems and to funders and others. So I'm going to turn this over to David Setiatti to present the clinical decision part of this presentation, where he will talk about how CME can be part of the daily workflow of the clinician. David?
Yep, great. Thanks, Bob. And thanks to the rest of the panel. Privileged to be a part of this panel, and hi to everyone out there that's joining this session. So what I want to talk about here is how it's possible to include all the different pieces that we talked about, all different parts of digital in a learning environment within the workflow of a healthcare practitioner. So as you can see on this slide, it's showing you a workflow of different stakeholders. At the bottom left there's a stakeholder of a patient. As part of the workflow, the patient can share their patient-reported outcomes, measures, as Dale mentioned, from their iPhone watch, different kinds of RWE and RWD. They could be validated measures, they could be surveys, they could be all kinds of different pieces, even including patient behavior. So sharing all that information and using that information for themselves independently. But and then on the bottom right, you see a clinician. That could be a nurse practitioner, it could be any HCP, could be a doctor, physician, that also is integrating or interacting with some sort of digital medium. So as we mentioned before, it could be some dissemination, they could be watching a webcast, they could be looking at things, or they could be using an interactive clinical decision support, where they could be asking questions and finding what they're looking for, and getting all that information. Now, all that is great as individuals, but imagine they can do that together. In fact, you don't really have to imagine it. It's possible today to integrate all that together, so you have all the different pieces of data. So as I mentioned, interactivity, you have all the measures, and you have all the behaviors which can occur at a patient visit. So that's at the top of the screen there, where the clinician and the patient are now learning from each other and learning from the data sets and the content. So imagine all the content stores can now support all the different data stores to provide a learning experience where an intervention can occur, where a change in treatment can occur, where a decision can be made, all enabled by that patient support and clinical decision support, and all that at the point of care in the workflow. So as I dig in deeper, what can that look like? And so now this brings in a number of different technologies. The main one being how we can use AI and cognitive to support that. So what you see here is a screen where a doctor has put in a question, a natural language question. So in this case, it's first line treatment for CLL. You can see that at the top. You can also see a microphone there. So you can also use, just like you would be using Siri or Google or whatnot, you'd be using it in this tool. The difference being is that the responses, in this case, 4 crisp responses, are not coming from the internet. They're coming from real, from CME vetted medical education, peer reviewed education, curated by the top KOLs. So as a doctor is asking this question, the AI breaks down the question semantically to give it context, and then searches across the entire content store of information, curated content store of information, to deliver the best responses to help that HCP right there at the point of care while they're looking to make decisions with their patient. So they get a crisp response that they can choose from, and they can use that information for their patient, but they can further that for even more learning. So there's a learn more button there at the bottom right, which they can go delve deeper into the evidence list, look for more information where this information came from, and look for more depth and breadth of that. But they can also use this for point of care learning. So they can already feedback and receive credit for looking at this information that has helped their patient already. And finally, they can disseminate this out by sharing or providing feedback right back into the AI, which allows more personalization for the next round. So lots of things happening on this, a lot of call to actions, but at the very basic point, you can ask a question and receive an answer right at the point of care.
And you have a thumbs up and down button to reinforce the AI learning to find out whether this is really useful information or not to the clinician, correct?
Exactly. So the thumbs up and down is a feedback loop and mechanism that allows personalization, which you can now do with digital. So that's not just dissemination, but now personalization and personalizing the engagement. So as you'll see on the next slide, we flip it on its head a little bit, and we take this, and not only do we just give answers, but we turn this into what we're saying a conversational learning experience, which means dialogue. So now you can have dialogue, in this case with the chatbot or digital assistant. So as you ask a question, the bot can come back and say, hey, listen, we know you're looking for this kind of information, but looks like we need a little bit more detail. Looks like maybe perhaps this is where you want to be looking towards, and really prompting them to have a deeper level of discussion or a deeper level of engagement, and a deeper level of learning. And I think as from the studies, and I'm sure Dale and John can feedback on this, from studies from game theory and from prompting, you're going to get higher levels of engagement, which means higher levels of learning. So as you can see here, they ask a question, they can provide deeper engagement, ask more specific questions to get even more answers. So it's really allowing a back and forth scenario between the learner and the education module, which you can't get with traditional CME as it is today, as just a dissemination platform. And finally, I'd like to show you a little bit of analytics that you get from this. So not only are the HCPs benefiting from this, but as the people in medical education, we get so much more depth from the analytics and insights that we get from people using these tools. So a good example here is on the top left. Just by looking at the questions asked, not even looking at the responses given by the tool, but just by the questions asked, we can break down the question intents to understand exactly. And in this case, we pulled this graph from a HEMONC question set just to show, well, wow, we can break down the questions based on not only therapeutic area, but a specialty within a therapeutic area. So lung toxicities as it reports for IRAEs, let's say in oncology, skin toxicities, treatment, diagnosis, measures. So we can see what questions are being asked to start thinking about what the gaps are that clinicians are having right there at the point of care as they're asking questions. And that fuels us to think about, wow, what a difference also between specialists and non-specialists and their knowledge difference. So we can start to target those gaps based on their profession and their specialty. So those are things that we wouldn't be able to do otherwise through just one-way dissemination. As you look at the top right, we break it down even further. We can now watch the learner flow and engagement. So as they ask one question, where does that get them? And what happens with their second question? In this case, you can see 10 questions being asked. So we watch the cohort of learners work through a learning module, and you can see they're asking questions all the way 10 questions in. And we can tell, are the responses coming from, do we have responses for their questions? Is there more learning needed? Are the questions off topic? Do they need to have some other intervention, maybe a contact us or maybe some more specialized learning? And we can watch all of that occur throughout the learning engagement and measure that effectiveness. So that allows us to also future train, allows us to make it more targeted, and allows us to be in the workflow better to get better responses quicker and faster for where clinicians need it most. And finally, the last graph I want to talk about is the one at the bottom left, and that shows how people are using the tools. And I think that's very important as well. When and where they use it, are they using it where they need it most? And from what we're seeing right now, from a workflow time day of engagement, this can be used right there at the moment of care, during the daytime, during their practice.
David and Bob, if you're open to it, just a 30-second perspective on this, because I know that.
Please, I was going to ask you and Dale and Doug to opine on this. I know that's your favorite word now, opine.
And I know that Doug has quite a significant material to provide too. So just making it really fast. Again, thinking about the supporter hat that I wear and thinking back to what I presented earlier, some of the things that David just shared are really powerful. So number one, having info at the point of care definitely meets a need of clinicians saying very publicly that they want to look more informed and be more informed in front of their patients at that right time. And then number two, having the ability to remain networked even after the initial point of educational engagement. So important because they're feeling disconnected. And then number three, imagine as a supporter getting additional outcomes beyond knowledge, competence, and practice improvement. But now you're getting outcomes about behaviors and basically why an HCP is making the clinical decision she or he makes. Very powerful. Enhances the kind of work that we do and the kind of message that we bring to the rest of our organization.
Thank you, John.
Bob, we've got a question from the CEC text line. I want to. It's kind of related to what David was talking about. So I want to throw it in. So here's the question: Is have you considered the challenges for patient input, and I would argue also learner input, with generational and cultural issues?
Wow, great question from out there. Yeah, definitely. Part of this is we're still learning. So first off, we're definitely considering all those pieces. So in order to make everything actionable and consistent, one was we make sure that everything that we're brought in from the patient voice and from learners, we try to make consistent. So there's a good way of having feedback. But that said, these systems and tools are meant to change and augment. So we can bring in the different disparities that learners may be facing, different disparities that patients may be facing, and include that in the process. And that's the great thing about digital is that it can change and it can be personalized. So the personalization is key. So the way someone looks at what they're seeing on their screen can be different and personalized to them than the next HCP, as I mentioned before, between specialists and non-specialists, or patients that have one particular area of treatment and another, or even comorbidities. So it's definitely under consideration, and we're always open to feedback on how to do it better.
Was there a change in the generational? I don't know if you have that kind of data. Is it the older user is not using this, or is there a mix across all generations, from younger adults to older?
It's a really good question, Dale. At first, we thought that there would be a generational change, and in fact, we're seeing high levels of engagement from all generations, from all spectrums. The younger and the older generation are the ones that are embracing it even more, believe it or not.
Thank you. Thanks, David. So I'd like to thank you, David. That's great, and thanks, John. So Doug, I'd like you to bring in your great technology, which I was immediately fascinated with as soon as I saw it. I'm so happy that you're part of the panel.
Great. Well, it's great to be here, and hello everyone out there. And what I want to do is focus on simulation technology and kind of broaden our view a little bit, and not look at just CME, but also look out at the corporate training environment, where they're actually investing about an order of magnitude more in education and training than we are in CME, and what can we learn from them? And what we're finding is that for simulation, the best fit is really in this skill-driven, learning component. And so, where in corporate training do they use it? They find two cases where they find it really works. You have to go to skill-driven learning, and that is, they invest a lot in knowledge acquisition, as we do in CME, and they're not seeing the pull-through to actually changes in behaviors and performance. And the two cases where that's occurring is, one, it's when the knowledge is more complex, a lot of variables, a lot of nuance. And second is when the actually implementing that knowledge in practice is high stakes and high risk. And when that happens, those two things happen together, they're not seeing the pull-through. And there's a lot of similarities with CME and medicine with that. And so what they're doing is then they have to go to skill-driven learning. And what that is from a cognitive science perspective is very different from this knowledge acquisition type learning that we do a lot in CME. And it's the focus there is really on practice, mentoring, and coaching. And I saw in that one the ARS response, it talked about practice specific topics, and this is when you're doing this, it's personalized, one-on-one. It's not one to many like a webinar. And when you're doing this, you could imagine how difficult it is to scale, because now you're talking about lots of coaches, mentors, subject matter experts. It's very challenging to do. And so it was really only being done in areas where there was the most impact, and they wanted to make it more broad. And so that's where simulation has come in, to be able to emulate that sort of one-to-one, type personalized experience using technology. And so that's really where it came from. And so this kind of that's some of the example of kind of the trends here of the technology trends for in the corporate training. And you can see that simulation and coaching and mentoring actually tied for number 2 in their investment here. And it's really driven by this need for scalable skill-based learning. And so I think we can learn a lot from what they've experienced here and apply it to CME. And so now let's just go on to the example here. So we're going to dive into this example here, and where you could see here, this is using game technology here. And back when we first started doing this 4 or 5 years ago in CME, the cost was really high. We were, it was, several hundreds of thousands of dollars to do these. It was all custom. It was very, time consuming. And now with the platforms that are available now, we can do this at a fraction of that cost. It's all done on the web now. And so some very different type of experience here. So what we're going to do is kind of dive into 2 aspects here. One is this whole coaching and mentoring, and give you an example of that. And then second, show you an example of a patient interaction. So here we're going to first dive into a choice here. You can see often here on the right here that there is a number of choices here that the learner has actually already identified their preference, their optimal choice. And now they're being asked, what are some additional options that would be optimal as well? So really pushing them. And so now what you're going to see when we start the video is that they're going to be the learner's going to be making that second choice, and you're going to see the virtual physicians responding. So go ahead and click. Okay.
Huh? But what about the TDF? Because this regimen contains TDF, it's probably not a good idea to have Bill continue taking it, considering he's at a higher risk of renal dysfunction.
I agree. Although this regimen is not absolutely contraindicated, it's not the best choice. If Bill's EGFR begins to decline, he would definitely need to be switched to a different regimen. In addition, efavirenz?
I'm sure you must have questions.
I do. I'm wondering if those changes mean I have to go back on chemo. I hope I don't have to. The nausea was terrible. I don't think my stomach can take that again.
Considering your blood counts and symptoms, we do need to look at treating you again.
I was afraid of that.
There are several options for treatment.
So you can see here that what we're doing is putting the clinicians and the learners in these realistic situations, and then asking them to make decisions, and then giving them more mentoring responses so they can start recognizing these optimal patterns that the experts are using. So they're practicing. And so the next question is, with their practicing, what kind of data are we getting out of that? And then the next slide, please. So you can see that we're capturing thousands of decisions from participants as they're putting in these situations or reacting. And it creates this very large data set here. And so what are the nuances that we can get from that data? That we can, first, if there's more than one optimal option, like we saw in that example, you can look at what do clinicians prefer? What decisions required the most mentoring? Which one were they're very competent in without any mentoring? And then you can look at specific choices, like we see over here on the right here, of where did they need the most mentoring? And here you can see this is for very early on, scenario 1, early decision. So they haven't practiced much yet. And you can see the mentoring level was 85%. So very little initial competency here. And then when they actually went through and did through 3 scenarios, by the time they did the third scenario, this dropped the amount of corrective mentoring in a similar situation dropped by 4-fold. So significant increases in competency went up to about 80% or 85% there. So that's you can measure that, and you can also then see what were they choosing instead of the optimal responses, what was suboptimal and inappropriate responses. And then we can go deeper, and we can actually then look at filtering the data by profession, specialty, experience level to really get some information on what are they specifically making, what kind of decisions they're making. And context is really important. So all this data is not very helpful unless you have the context of the specific situation that they were in when they made the decision. That's really what we want to report out. And as a final point, that there's a lot of data here. So what we're doing is now is we're working through AI, machine learning algorithms to actually be able to pull out some of these insights automatically using the analytics engine, so that we can identify these insights faster. And all this then can get fed back into future CME programs, with the data on what we're seeing from the physician responses from the simulation.
All right, Doug, we have a question that came through the CEC text line specifically for you. So I know we got a couple of minutes left here, so I just want to throw this at you now. So it says, the value of simulation from education psychology is bringing learners to doing. How are you getting learners to doing online?
Yeah. So it's really that it is learn by doing. So it's really the whole structure of what this is what we're doing, saying, what is the practice gap? What are they doing? What should they be doing? What are they not doing? What are they doing now? That becomes the decision, and allowing them, then putting them in that situation and allowing them to actually make a decision, and then getting that mentoring feedback. So what we're doing is emulating what you would see in like grand rounds with a mentor there, and we're trying to we're emulating that in software.
Any other questions, Scott, for anyone on the panel, since we're close to calling it?
Yeah, there's one more good question that I think probably a lot of people are thinking about that came in on the CEC text line, and this is really for anyone. Mm-hmm. What are some of the initial, most basic steps a healthcare organization can take to start embracing AI for CME in times of budgetary constraints?
Mm-hmm. Interesting.
I think that, Bob, that's a realistic question. It's one thing to be able to talk about innovative approaches and then to talk about how much that costs. And it must be really frustrating and sometimes challenging for a provider to hear a supporter say, yeah, we're really interested in that. Oh, but we don't have the budget. We don't have $500,000 to spend on one activity. I do think that there are methods that can be put into a place that keep costs down, or at least scale costs, by using some free technologies that exist out there, integrating that into the idea and the platform that might already exist, working with a health system that already has a platform in place and bringing the educational design to that health system's platform, somewhat of what you mentioned earlier, Bob. But I do think that that's the reality of the conversation now, and something that needs to be explored further. But just keep in mind, simulation, that example that Doug just shared, that's excellent. And there are needed areas for simulation. Digital doesn't always have to be simulation. It can sometimes be something that is a very strategically positioned tool, like through an iPhone, an iPad, or something very to the tune of what David presented earlier that captures that same amount of data.
And I would just jump in. I would certainly echo all that and say that health systems and health institutions are looking to partner with companies that have this technology. They're always looking for partners. So it doesn't necessarily have to be a barrier with funds, because bringing in a health system and having that health system as a partner, let's say in any of these processes, also adds to the value. And everyone's seeking partners of value, and a health system certainly is a partner of value. Bringing their audiences to the technology, would be a great partnership for them to consider.
And if I may, Bob, I think one of the things too that could be done, which may not cost a whole lot, is the gift of time. So many times we're so busy with things, it might be nice to be able to give the time in the week, an hour maybe or two, or maybe it's once a month, but at least give time to the employees to go to look for the education that exists on many different platforms. I think that's one thing that employers can do to help with the digital divide. digital divide and helping people to become more attuned to AI and its use as a tool.
All right, I know we have one more ARS question before we close this down, so I'm going to go to that now. So this is sort of the what did you take away from this session? So this is our peer audience ARS question. What one choice best now describes your perspective after our discussion? This is sort of our post-test question. So I will fully embrace and use a digital learning strategy. I don't fully understand the differences between online visual learning and digital learning. I think I understand the differences, but I do not think I possess the capacity to deploy or support. I do not believe a digital platform provides any diverse benefit, or I think digital is simply the next buzzword. Okay. So we'll give people another couple seconds. So I think that this is pretty good. This is looks a little bit similar to the pre-test data, but certainly that people are kind of willing to adapt a digital learning strategy.
Yeah, definitely. It looks great. So while we're just watching the last of this come up, I just want to thank everyone, John and Dale and David and Doug, Scott and Derek for putting CME Palooza together. Great job on your side. Thank the audience for participating. We can always be reached, through emails, and happy to continue the conversation. And thanks to everyone for participating. And I'm happy to see this post-test question. Essentially, I think we got rid of the buzzword part, so that's good.
Yeah, we did.
we got rid of the buzzword part, so we did our job.
Okay.
All right. Thanks. Thanks so much.
For people who are watching this session, there is a brief CME Palooza Spring survey. We've cut it down to only 4 questions now, just to give us some feedback on how we're doing. And for those who are watching this live, to view our next session, which will start here in about 3 minutes, if you're on the live page, you can just click the appropriate link, and that session will start shortly. So with that, I'd like to thank Bob and John and David and Doug and Dale, and thank everyone for watching. And we will be back with our next session momentarily.
Thank everyone. Thank
you. Stay well.
Bye.